Welcome, everyone. I see people are coming in from the waiting room, so I'll give a few moments before going through some housekeeping. Okay, looks like the waiting room was quite full. We're going to give everyone one more minute and then we'll get going. Okay, terrific. So thanks everyone for joining us today. We're going to be having an excellent talk on fever in the returning traveler, epidemiology and initial management. My name is Erica Shenoy. I'm an infectious diseases physician at Mass General Hospital and medical director of the Regional Emerging Special Pathogens Treatment Center here. Before we get started, just a few housekeeping rules. So this webinar is being recorded and the recording will be posted to the RDHRS website. To limit background noise because of the number of attendees that we have, your microphone has been muted for the duration of the webinar. Please send questions and comments. If you have a question or comment at any point during the webinar, you can type it into the Q&A box. So check out the Q&A box, not the chat, the Q&A box at the bottom. And then I'm going to be kind of collating the questions as we go through and putting them together for the audience Q&A session at the end. At the end of the webinar, we're going to be sharing a link to a short survey to gather your feedback. This information is very helpful to us to help us to develop future sessions and identify topics that would be of interest to you for future webinars. We really appreciate your time. It's about 60 seconds, and we promise that it's that short. So I just want to acknowledge that this webinar is presented by the Regional Emerging Special Pathogens Treatment Center, the RESPTC, in collaboration with the Region 1 Disaster Health Response System, which is the RDHRS. Both programs are funded by the Administration for Strategic Preparedness and Response, or the ASPR. Next slide. The disclosures, so the content provided in this webinar is presented by the individual speakers only, does not represent or reflect the official policy or position of any portion of the United States government. You can see the rest of the disclosures here, and importantly, the speakers have no affiliation or financial interest or relationships to disclose. Next slide. So let me just take a moment to introduce my colleague, Dr. Jake Lazarus. So after completing his residency and fellowship at Mass General Hospital, where he did his fellowship in infectious diseases, Dr. Lazarus joined the faculty here in the Division of Infectious Diseases. His research interests include antibiotic resistance in nosocomial infections, and as a member of our Regional Emerging and Special Pathogens Treatment Center, the evaluation and management of patients with suspected and confirmed high consequence diseases. And he's going to give us a terrific talk on what to do if you have a returning traveler who presents with a fever. So I'll turn it over to Dr. Lazarus.
Thanks, Dr. Shenoy, and thanks everyone for attending. Fever in the returning traveler is an important topic, both from a clinical perspective, but also from an infection control and prevention perspective. I'll be talking about both today while highlighting what you should know about the epi and the initial management of common tropical infections. So this is our roadmap. I'll provide a high-level overview of the epidemiology of fever in the returning traveler. I'll then review essential components of the history for such a patient. I'll speak about diagnostics with a special emphasis on malaria. I'll describe the clinical presentation and treatment of some less common but potentially fatal diseases. I'll guide you to resources that you can use for country-specific outbreaks. And I will close by emphasizing the components of the identify, isolate, inform framework using Ebola virus disease as an example. So why is this topic important? Common causes of fever in returning traveler, such as malaria and typhoid, can be fatal, yet they are eminently treatable if we recognize them. On the other hand, uncommon causes such as MERS or Ebola, if undetected, can cause large, deadly healthcare-associated outbreaks that can spread into the community with disastrous consequences. And this topic has become increasingly important over time as foreign travel becomes more common. You can see here that in the year ending 2019, international flights to the US had doubled since 2002. This, of course, decreased substantially earlier in the COVID pandemic, but all indicators are that the pace of such travel is picking back up. As we learned from COVID, more international travel means more potential for rapid spread of pathogens across borders. Of the tropical and subtropical causes of fever in a returning traveler, there are a handful that we must all be familiar with. Malaria, about which I'll go into further depth, is common and it is deadly. The second most common diagnosis, dengue, is a viral infection transmitted by mosquitoes. It can be severe, but because there's no specific treatment, I'll prioritize other topics today. Enteric fever, aka typhoid fever, is caused by either Salmonella typhi or paratyphi, rickettsial tick-borne infections. These are both also common enough infections and are easily treatable. So let's talk about the essential history and then the physical exam in a patient with fever. So in addition to the usual history appropriate for any patient presenting with a fever, and a person returning from foreign travel, additional history is necessary to construct a well-ordered differential diagnosis. It's important to establish when the symptoms began in relation to the return from travel. This is because different infections have different incubation periods. As an example, the usual incubation period for rickettsial infections extends out really to only about 18 days. In contrast, even in the more acute forms of malaria caused by falciparum malaria, you can see a significant number of cases presenting up to 30 days after return. And for another form of malaria, vivax malaria, cases can pop up for months or even years. Determining the precise nature of the travel is also critical. Clearly, though people sustain mosquito bites and acquire malaria, even in urban areas, the overall risk will be quite different for a business traveler that only briefly leaves their hotel compared to a rural holiday spent with family for weeks. Also, in these situations, country-level information on travel is an important beginning, but is not sufficient. As an example, malaria is endemic in Peru, but while people traveling to the Peruvian Amazon are high risk, travel to urban Lima, highland Cusco, or itineraries involving Machu Picchu, this present no malaria risk. Detailed review of the activities and exposures that occurred in country is also necessary. While travelers might not remember having bit by mosquitoes, you'll occasionally get histories like, oh yeah, I got bit by a ton of mosquitoes. This is obviously valuable to know. You should also ask about animal exposures. This can increase the risk of leptospirosis, which I'll discuss, but also rabies. And what about sex? Many travelers have sex on vacation or travel specifically for sex, and in this context often have sex with commercial sex workers. Acute HIV is a common enough cause of fever in a returning traveler with an appropriate history. Consumption of unsterilized water or street food considerably increases the risk of typhoid or the more usual traveler's diarrhea. And did the traveler seek pre-vaccination care? I can talk more about this in the Q&A if you have questions, but in addition to malaria prophylaxis, there are many steps travelers can take that they often don't to reduce their risk of infection. Moving on to the essential part of the physical exam, this is also crucial. As always, this starts with vital signs and general appearance. Some patients may be actively febrile and appear ill in front of you. The suspicion for malaria or severe dengue should be especially high in these patients. Examination of the skin is important, since a characteristic rash is often a crucial clue in these patients. Travelers with incomplete vaccination, for example, are at risk for measles, which is not the focus of our talk today, but is a travel-acquired infection with considerable infection control implications. Tick-borne rickettsiosis, which I'll speak a bit about, can also cause characteristic rashes, often with eschars. Meningococcal meningitis, which is relatively rare in the US, but has occasional large seasonal outbreaks in sub-Saharan Africa, can of course cause a characteristic rash and requires prompt recognition and antibiotics. Regarding the abdominal exam, hepatosplenomegaly can be seen in both typhoid and in malaria, patients should undergo a complete anogenital exam. Thankfully, monkeypox cases are waning, but syphilis remains a common cause of anogenital lesions and fever. Finally, signs of confusion and lethargy should always concern us, but in the context of malaria, suggests the presence of severe disease and portends a poor prognosis. These are the essential initial laboratory tests, but of course should be personalized for the risks incurred by the patient in front of you. The CBC with DIF should be done to investigate for cytopenias, but an eosinophilia, if found, can be include a less common parasitic infections. Liver enzymes can be elevated in many of these syndromes. Blood cultures and less often stool cultures may be used to diagnose typhoid, but of course, common things being common, also the usual community onset bacteremia. I'll next speak about testing for malaria, which is appropriate in every traveler returning with a fever with even a somewhat plausible exposure history. Okay, so why evaluate for malaria? Why am I focusing so much on malaria? Because it is common. In several large series, it's the cause of anywhere from 1/5 to 1/4 of fevers resulting from tropical infections. It's endemic in South America and Asia, but is especially common in travelers returning from sub-Saharan Africa. It's also deadly. In several large cohorts of patients, malaria is responsible for the vast majority of fatal cases. Importantly, it is also eminently treatable. The CDC has performed deep case level analyses of fatal malaria cases in American travelers, and they found that these deaths are due in about half of cases due to delayed care seeking by patients, but in the other half, due to an initial missed diagnosis or to inappropriate treatment once the initial diagnosis is made. Okay, well, at this point, you're probably asking, how do I know if my patient is at risk for malaria? Well, you have to determine if the patient traveled to a region with endemic malaria. Below is a map released by WHO last year. It serves to emphasize that a significant proportion of the tropics has endemic malaria. However, though this map has a large majority of the tropics in the red, malaria is not evenly distributed here. So you must obtain a country and a region-specific travel history from your patient. How to do this? I will admit it, besides the rare ID tropical super expert, we all look this up every time, and so should you. So what I do is I just perform a web search for CDC, malaria, and then whatever country is of interest. And that takes you to the below web address, which has a fantastic table with hyperlinks. Let me show you. So you can see that this includes not only country level information, but also region or administrative district level and city level information within the country. And outside the scope of this webinar, but very important, accessible here, information on which Plasmodium parasites are present and if malarial drug resistance is a concern. So some countries will be easy. Travelers will be at risk in essentially the entire country, like Nigeria here. Other countries, like many smaller South Pacific islands or urban microstates like Singapore, have essentially no or very low malaria risk. Some depend on elevation. You know, here is a description of the Peru example I was talking about before. You can really see how crucial it is to elicit sort of highly granular travel itinerary. So another important risk factor is, did the patient take malaria prophylaxis? Prophylactic medication, if taken correctly, substantially reduces a patient's risk for malaria. But importantly, and we often do a poor job of explaining this to patients, and so it's not done correctly, all antimalarials require initiation prior to entering a malarious area and continuation for a time after leaving. You can see how this would be confusing to patients. The dosing varies by agent. Certain agents are preferred for certain travelers and for travelers to certain regions. You can easily find this information by searching malaria prophylaxis instructions. which takes you to the relevant part of the CDC Yellow Book. I'll reference the Yellow Book throughout this talk. It's available for free online and is a great resource for both general and for more point of care learning. I do need to emphasize that even with perfect adherence, no prophylactic anti-malarial is 100%. Okay, so clinical features of early complicated malaria. These are non-specific and really emphasizes the importance of a complete history to facilitate, an appropriate level of suspicion on your part. Common symptoms of uncomplicated malaria are fevers, chills, malaise, headache, nausea, vomiting, abdominal pain, and diarrhea. These are non-specific. Cytopenias are also frequently seen, with thrombocytopenia being more specific for malaria than anemia. LFT derangements can be seen in many infectious causes of tropical fever. Hyperbilirubinemia is an especially important clue to malaria because of underlying hemolysis. As the disease progresses, patients are at risk for ARDS, shock, DIC, profound metabolic abnormalities, and concerningly, the syndrome of cerebral malaria. This is an encephalopathy of gradual or sudden onset. Occasionally, patients will have seizures. This syndrome is more common in travelers without the prior partial immunity to malaria that residents of endemic area frequently develop, and is very worrisome. Diagnosing malaria. Because the disease can be fatal, the turnaround time for testing should be truly rapid. This is why every medical facility should have a malaria testing plan. This can't be a send out, and if rapid results of testing are not possible, the patient should be referred to a center where the results can be truly rapid. There are two main diagnostic tests. The classical test is blood smear interpretation. In this test, which is relatively labor intensive, blood is smeared onto a slide that is then examined microscopically for the presence of Plasmodium parasites. It requires the maintenance of considerable expertise on the part of the lab technologists that perform this. Because of this, and because in most centers, even if there are technologists qualified to do this, it's not available 24 hours a day. Smear is increasingly being used not as the initial diagnostic test, but as a confirmatory test. The second main test, the rapid diagnostic tests, are becoming dominant, including at our own hospital. These are performed using lateral flow test kits, which I'll show you on the next slide. These are similar to the COVID-19 antigen test kits, with which I'm sure you're all familiar. These tests can deliver results in 30 minutes, and if the result is positive, is a very reliable test. Okay, so here you can see an example of a positive rapid malaria test. At the top, you can see the control line. Examining the T1 and T2 line, you can interpret this using the information provided on the card. You can see that this patient is infected with Falciparum malaria. This is the most dangerous species of parasite. So a positive test like this should prompt immediate treatment, and blood should be sent on for smear microscopy, both for definitive species level identification, but also quantitation of parasitemia. The amount of parasite in the blood correlates roughly with the severity of illness, at least in non-immune hosts, like the travelers you'll be frequently encountering. The smear can also be followed to confirm a microbiologic response to anti-malarials. That is, the amount of parasites decreases with the administration of malaria treatment. A negative rapid antigen test, because the sensitivity is not 100%, should prompt repeat rapid antigen testing in most circumstances, if there's even a marginal post-test probability that remains. If you can obtain the results of smear microscopy within 24 hours, waiting for these results is also reasonable. And if the negative antigen test is felt to represent a true negative, then this is great, since you've ruled out one of the most common causes of death in these patients. All right, treatment of malaria. So initial treatment of malaria prior to species level identification is now universally recommended to be with artemisinin-based regimens. These drugs have largely supplanted older drugs with which you might be familiar, like quinidine or quinine. Treatment can be oral if this is uncomplicated malaria, but even if the patient appears relatively well, to get a sense of their clinical trajectory, they should be observed for 24 hours to ensure that they are clinically stable, and ideally to also confirm that they have a microbiologic response to the therapy that you've started. If the patient is ill, the preferred therapy is parenteral artesunate, so IV artesunate. This previously had to be obtained directly from CDC, and for our center, it needed to be flown into Logan. But thankfully, this is now available commercially and can be added to formularies. Because the risk of death due to severe malaria is greatest in the first 24 hours after presentation, and the preferred therapy for severe disease is parenteral artesunate, every healthcare system should have a plan for rapid sourcing of this drug and for its administration. For example, we keep a supply of this on site so it can be rapidly administered here. We are the most common hospital in our system to which malaria presents due to our proximity to Logan. But we also have a plan to either transfer the patient to us or to transfer the drug to other hospitals. If the patient must be transferred, many would give an initial dose of oral artemisinin-based therapy prior to transfer. You can read more detailed guidelines from the CDC at the link in the bottom of the slide. Okay, all right. So malaria is important. Malaria is important. Let me talk about briefly a few other can't miss diagnoses that can be severe but are treatable. So the first is enteric or typhoid fever. This is a water or foodborne infection caused by either Salmonella typhi or Salmonella paratyphi. It's present worldwide, but has the highest incidence in travelers returning from Asia and Southern Africa. Patients generally present with abdominal pain, fever, and chills. This can be a difficult illness to diagnose because, unfortunately, non-culture-based testing is of limited value, and neither culture of the blood nor of the stool is highly sensitive. So often in a returning traveler with compatible epidemiology and compatible clinical syndrome, treatment is empiric. If hospitalized, ceftriaxone is a good choice. Because fluoroquinolone resistance is rising worldwide, azithromycin is likely a better oral step-down agent. Again, refer to the CDC Yellow Book for further information. Tick-borne rickettsial infections. In the US, exemplified by Rocky Mountain spotted fever and rickettsial pox, are especially common in travelers returning from sub-Saharan Africa, particularly those with safari itineraries or other rural exposures. Diagnostics are available, but these are usually send-out tests. So in a patient with fever, headache, and especially either single or multiple ASPRs, doxycycline is the drug of choice. Another rarer infection presenting in this way, especially in these same travelers, returning from safari, would be cutaneous anthrax. For cutaneous anthrax without systemic involvement, doxycycline is also a fine choice. Final diagnosis that I want to speak about briefly is leptospirosis. This is a spirochetal illness that's fundamentally a zoonosis, but with a very widespread distribution of its diverse rodent and mammal reservoirs in the developing world. So because of this, most exposures are not directly from animals, but instead when travelers are exposed to animal urine contaminated water. Lepto causes again, a non-specific syndrome, fevers, rigors, myalgias, and headache. Classically, there is suffusion of the conjunctiva, but this is not always seen. Disease can be severe and rarely lead to multi-organ failure. About once a year, we see such a case at our hospital. Diagnosis is best confirmed by PCR. Treatment for severe disease is either with doxycycline, penicillin, or a third-generation cephalosporin. All right, so as I reviewed, malaria and other tropical infections are important causes of fever in the returning traveler, and they are important because they are less familiar and they can be fatal if missed. However, usual causes of febrile syndromes are still more common in these patients and certainly make up the absolute majority of infections. So don't forget bacterial pneumonias, spontaneous community onset bacteremias with staph, streps, UTIs in a patient with compatible symptoms, or viral illnesses like flu or COVID or RSV, all of which we're dealing with right now, or sexually transmitted infections like acute HIV, or secondary syphilis can present this way as well. All right, so we've spoken about relatively common, can't miss tropical infection. We can't miss them because they are treatable and can be fatal. Let me shift gears here to another bucket of can't miss infections. They also can be quite fatal, but they're also can't miss because of the infection control and prevention implications. So let's start with a case. All right, so you are on call and you get paged. Please call 28-year-old man 7 days back from visiting family in Uganda, presenting with fever and diarrhea. All right, so based on what I just told you, there are a few infectious syndromes that can cause non-specific symptoms like fever and diarrhea. This could be anything from malaria to typhoid in the right exposures. It could be dengue. So a complete differential diagnosis should start. A granular travel itinerary should be obtained. So these things would be more common. But what else could this gentleman be at risk for? Okay, so what I do every time to make sure I'm not missing country-specific outbreaks of concern is to do a web search, the country of interest and CDC. So this will take you to a specific country page where you will be reminded that there's currently heightened alert because of a recent Ebola outbreak in several districts in Uganda. But very helpfully, if you scroll down on this page, you'll also see other infections that the traveler is at risk for from Uganda. Note that many of these infections are vaccine preventable. Everything on this list from cholera up through yellow fever has vaccines of varying efficacy. And the rest, can be prevented through other aspects of pre-travel counseling, such as mosquito avoidance and repellent strategies. So again, important. All right, but focusing on the current Ebola virus disease outbreak in Uganda, I'll talk about both its epidemiology and its clinical manifestations. So Ebola virus disease is thought to reside between outbreaks in a zoonotic reservoir, bats, though it's increasingly recognized that there may be subclinical viral persistence in the rare human host that can restart outbreaks. There are 4 distinct Ebola viruses that cause human disease. Since the illness was first recognized in the 1970s, there's been a few handful of distinct outbreaks in Central and West Africa. Usually these outbreaks were small and relatively contained, but from 2014 to 2016, you're likely aware of an unprecedented large outbreak which occurred in West Africa. 11,000 people died and nearly 30,000 have confirmed or probable infection, though the actual number of dead and infected may have been much higher. This really emphasizes the destructive potential of Ebola, especially once it gains access to large urban areas. The outbreak was eventually controlled through improved infection control and prevention in hospitals, significant community messaging regarding safe nursing and funeral practices, and likely to some extent the availability of an effective recombinant Ebola vaccine. This vaccine was designed specifically for the Zaire Ebola virus, which caused this outbreak. A smaller proportion of outbreaks have caused by the Sudan virus, for which we would not expect this vaccine to work well. As you can see, the case fatality rates for both of these Ebola viruses is quite high. Early in the COVID epidemic, we were afraid of fatality rates approaching 5 or 10 or even 20%. But as we identified more cases, we knew that even prior to vaccination, the fatality rates were actually much lower. This is probably not the case in Ebola. It is an inherently quite disease with quite high potential for morbidity and mortality. All right, so clinical manifestations. The incubation period of Ebola is anywhere from 2 to 21 days after exposure, but usually it manifests in 4 to 17 days. Unlike COVID or flu, it is not thought to be infectious prior to symptom onset. The disease caused by the Ebola viruses was previously often referred to as Ebola hemorrhagic fever, but the new preferred term is Ebola virus disease. And this is meant to de-emphasize the major bleeding, which is actually quite rare and only occurs in some late, usually fatal diseases. So we have to recognize Ebola before it causes hemorrhage. Early in the disease, this is a recurring refrain. You can see that majority of symptoms are nonspecific: fever, headache, fatigue, myalgias, arthralgias, vomiting, diarrhea, so malaria, typhoid symptoms. You can see the overlap here. And I don't think you'll be surprised, but of the activations we've had at our center for possible Ebola or other fevers like Ebola, many have been identified relatively quickly instead as malaria. All right, so in late September of this year, the Ugandan Ministry of Health declared an outbreak of Ebola caused by the less common Sudan virus. There were 2 peaks to this outbreak. Overall, the fatality rate was 40%, but thankfully, there have been no new cases since late November, though surveillance still continues and is intense, and there is potential for more cases. This has been a great opportunity to renew our preparedness for Ebola, and is also an important motivator for development and testing of vaccine targeted towards Ebola Sudan. How is Ebola transmitted? It's transmitted through contact of infected body fluids with broken skin or with mucous membranes in a susceptible individual. I've listed fluids here that have been confirmed to be infectious. While airborne transmission has not been documented, because of the consequential nature of nosocomial transmission, aerosol generation should be strictly limited, and PPE use must be meticulous. This is because Ebola virus disease has the potential to cause explosive and fatal nosocomial outbreaks. During the 2014 to 2016 West African Ebola Zaire outbreak, the incidence of confirmed cases in healthcare workers was 100-fold higher than the general population. Numerous, well-documented, tragic, large clusters were described due to lapses in infection control practices. But, as a useful counterexample, for healthcare systems with robust, consistent infection control practices at baseline, the risk is likely substantially mitigated. There's an instructive example of a person with Ebola virus disease who was failed to be initially identified and was admitted to a South African hospital. But despite this, an unidentified case of Ebola being admitted, because of excellent baseline infection control practices, of 300 potentially exposed healthcare workers, only 1 was infected. So this emphasizes, the standard precautions that we take on a daily basis. These days including masking, but also gloving with any potential exposure to body fluids, and hand hygiene before and after patient care. Okay, so I'll talk about the classic identify, isolate, and inform framework in the context of Ebola virus disease. This is especially important for Ebola and for other high consequence infectious diseases. So importantly, every healthcare system should have a framework in place to rapidly identify high consequence infectious diseases. This is an example of one resource that we use internally. It requires a fair bit of effort to keep fully updated. You can see here, it's an easy way for those of us who are in our regional emerging and special pathogen center and our emergency department colleagues to, by country, identify the infection of interest. And there's also hyperlinks to more detailed virus-specific protocols that we keep up to date in-house. This allows rapid implementation of the two other I's, the isolation and the informing hospital and state level authorities. This is an effective method, though relatively low tech, and it may be appropriate in many circumstances. However, we found that this requires busy, primarily ER providers to jump out of our electronic medical record, which is realistically quite difficult given how busy RER is. It also requires continued teaching and reteaching to ensure that clinicians know what to look for and where to find next steps. This allows some residual potential for patients with important exposures to fall through the cracks. Because of this, we have implemented additional higher tech measures. Increasingly, we are turning to EMR-embedded clinical decision support tools, like you see here on the right. This was the decision support tool we developed to help us with monkeypox identification and infection control and testing. We usually integrate these with best practice advisories. Such a tool was also crucial to relieve clinician burden during COVID-19. As I said, was very helpful for monkeypox. We've implemented similar symptom identification systems that incorporate travel data. This travel data is collected during initial nursing patient triage, and through these best practice advisories can alert the clinician to the possibility of a high consequence infectious disease. All right, so here's an example of our in-house screening adapted from CDC guidelines once a patient has been identified as having travel history to a country with recent Ebola virus transmission. You can see here that internally, at least, we are extra cautious, and we include the Democratic Republic of the Congo in our Ebola screen. Even though there are no recent outbreaks, we think the frequency of small outbreaks over the past several years warrants extra vigilance. For infections like Ebola virus disease, even though the overwhelming majority of travelers will not have Ebola, it's important that we have an alert generated every time. Then, if upon further assessment to see if symptoms overlap with potential Ebola symptoms, if the patient does not have Ebola compatible symptoms, we can redirect focus towards a more usual clinical workup. So if the patient is identified as having both a travel and exposure history that's compatible, as well as symptoms with Ebola virus disease, we implement enhanced isolation. So the patient is placed in a private room. We ensure they are wearing a surgical mask. And at this point, except when necessary, we avoid direct contact, except for our specialized teams of clinicians that are trained in proper use of enhanced PPE that's listed below. I've also provided a link to CDC guidelines on PPE for patients under investigation for Ebola. We also place very special emphasis on proper donning and doffing of PPE, which is often a place where this protection can break down. And importantly, to limit exposure time, much of the additional history can be obtained through telephone or other means. After the patient is isolated, you identify potential Ebola virus disease, the case should be escalated to the relevant public health department. In situations like this, public health can provide further guidance as to whether to formally consider the person at risk for Ebola and whether to proceed with testing. Such patients may be appropriate for transfer to a specialized regional special pathogens treatment center, like us or another center that can provide the clinical and lab facilities necessary for these patients. Okay, so let me summarize what we've talked about in this webinar and emphasize what I think are the most important points. The first is that this is an important topic since foreign travel is becoming more common. Malaria is by far the most frequently fatal tropical infection in a returning traveler with fever. Because of this, we must all have a site-specific plan for malaria testing and for malaria treatment. For each returning traveler, every time use a country-specific resource to ensure that you're considering relevant infections. I do, Dr. Shenoy does. During this process, you'll identify patients that may be at risk for high consequence infections such as Ebola. These patients should then be isolated immediately, and infection control practices should be engaged. Finally, inform public health officials to facilitate further diagnostic and management. Thank you so much for attending this webinar. Dr. Shenoy and I should have time for questions. If you could, this is a QR code for this brief survey to which Dr. Shenoy was referring earlier. We really do appreciate your feedback. All right, thanks, guys.
Well, that was terrific. I feel like I've seen that material before, but I learned a lot there, and really want to thank you for a great talk. So definitely take a look at the Q&A button, add questions. I had a few that I could get us started off with,
Sure.
not to put you on the spot, but so as we know, in infection prevention, an ounce of prevention is worth a pound of cure. So I'm thinking about all the people right now who might be going to visit family and friends for the holidays, and the importance of clinicians being attuned to that, and then either providing the travel advice up front that is relevant, or directing them to a place that can provide formal travel, pre-travel counseling. So maybe you could give some thoughts on how any clinician can provide pre-travel guidance.
Yeah, this is often a real missed opportunity. Of course, there are special pre-travel clinics. Many of your centers may have them. We have them. But the CDC Yellow Book and also the CDC country-specific pages are really good resources for this. I go there every time to check which infections the patient is at risk for in the countries to which they're going. I know that the docs in our travel counseling center, which do this all day, every time, go to those pages. We often overlook this, but pre-travel counseling is a valuable opportunity, not just for vaccination, but for other counseling. So I emphasize the vaccination and the antimicrobial prophylaxis, but there are behaviors that travelers can engage in to stay healthy. So the most dangerous activity that most travelers perform is driving or being driven. Travelers need to wear seat belts and preferably only drive with licensed or accredited drivers. Other topics that are important: sun protection, mosquito repellent and behavioral avoidance, minimizing exposure to water, foodborne pathogens. If they're going to high altitude, how to minimize altitude illness, or what to do when they recognize it. Minimizing alcohol is crucial to decrease their risk of potentially injurious behaviors. I also discuss safer sex, and we'll prescribe HIV pre-exposure prophylaxis or bacterial STI prophylaxis if important. Doxycycline can be a useful malaria prophylaxis, and we increasingly know that it can also prevent syphilis, chlamydia, and maybe even gonorrhea. I also let them know what symptoms to watch out for while they're traveling or when they return. In addition to the vaccines that we think about as being appropriate for tropical illnesses, this is also a great time to make sure that they are vaccinated against other things like measles, make sure that they're up to date on polio, but also flu and COVID, and a recent Tdap.
That's terrific, and I'm thinking that I'm glad you put the measles in there too. There's a resurgence of measles around the world, and actually right here in the U.S., I think in Ohio, there's an ongoing measles outbreak. So you're not wasting any opportunity for preventive counseling. I love it. There is a question about putting the QR code back. So if we could leave the QR code up. I have another question, so I'm just going to use my pulpit here, and people are welcome to put other questions in the chat. So it's great that it appears that the outbreak in Uganda is getting under control. Obviously, there's a time frame during which there'll have to be no cases for everyone to kind of breathe a sigh of relief and hopefully address sort of some of the conditions that led to the outbreak. But one of the things that this outbreak raised was there's no vaccine. We have a great vaccine for the Zaire strain, but there's nothing for Sudan, or there's nothing that's approved or had been really extensively tested. Can you talk a little bit about what we know about vaccine development for the Sudan virus?
Yeah. As we all know from continuing to live through COVID, this is a really exciting time for vaccinology. As I mentioned, vaccine against Ebola Zaire was tested and shown to be effective in the 2014 to 2016 West African outbreak. But vaccines against the Sudan virus have been designed, but because these outbreaks are less common, they've yet to be tested. Thankfully, the outbreak seems to have terminated, but the leading candidate for future outbreaks would probably be a slightly modified version of the recombinant VSV vector-based Zaire vaccine. The manufacturer of this vaccine, I was just reading about this last week, apparently has a large amount of frozen vaccine ready to be filled and finished. So now that we know that, we can hope that this vaccine, which I would think would be effective, will be a great tool in aborting other more sustained Sudan virus outbreaks. And like I said, we never like hearing about an Ebola virus outbreak, but the silver lining is the preparedness that we're talking about now, and the preparation to test this vaccine against Sudan virus.
So there's a question in the chat, and I can start off answering this because Dr. Lazarus and I are partners in crime in developing some of these tools that we love to develop in EPIC to guide and provide customized basic decision support for our clinicians at the point of care. And we've developed these for COVID, for monkeypox, for some more routine infections like MRSA, but we have been in discussions with EPIC. We are planning probably some form of a webinar in the spring. We did one earlier that I think is recorded on the monkeypox tool and describes some of that work along with other builds that we had created to support the monkeypox response. So that content is online, at least related to monkeypox. But for the most part, some of these tools do require some customization. Not all hospitals that have an EPIC installation will be able to plug and play. These aren't totally plug and play, but I think the conceptual approach of what is the essential information, you can guide a clinician to ask these questions, obtain this information so that when they call the local infection control contact, when they call, when they're prompted to call the infection control contact, prompted to call public health authorities, that all the information is right there for them and they don't have to look something up. For right now, for our viral hemorrhagic fevers, we are using a pen and paper tool as we develop the one for viral hemorrhagic fevers in our EPICs. So we are definitely excited to share that work with others, and we'll do so through a variety of means, either publications or through holding some EPIC webinars. On that point, Dr. Lazarus, did you want to add anything to that? We could go on to how screening patients in ambulatory care versus other locations.
No, nothing to add. I think that we have found here in situations that we've implemented it already, and like you were talking about it in situations that we're working on, that it's an additional safety measure to make sure things don't fall through the cracks, but also to acknowledge that just like surgeons need checklists and tools, the rest of us need them too for rare, highly consequential things. Yeah, I love working on these.
Okay, so do you recommend that all patients throughout ambulatory care be screened for travel and symptoms, or just locations at most risk for walk-in patients and recent travel and symptoms, such as EDs, OB triage, and other high-risk locations? So a lot of this is going to depend on what your healthcare facility decides, what are the high-risk locations. However, I would say that one of the things we also learned recently with monkeypox is that we do a lot of triage on the phone when patients are calling in for a sick visit, and that is a good time when someone is presenting with fever or other symptoms, to get some basic information that could help decide where the best place for evaluating them may be. And so I think ambulatory is a very large place, and for the most part, the visits there are unlikely to you're unlikely to encounter someone presenting with these acute symptoms, because they would perhaps present to urgent care, an emergency department, or other locations. However, it's still very important for the clinicians and those triaging patients to at least have that information they might need, so that if they identify something, they know what the next steps are. And so how you implement that and how far you go in terms of whether or not you are going to mandate a formal travel screen in all these locations, it's really at the facility level to think through those decisions and determine how much additional identification of patients is likely to happen using those sorts of tools. Dr. Lazarus, any thoughts on that?
No. And to sort of expand, you can also imagine that this might depend a lot on how active an outbreak it was. This probably wasn't necessary for the initial parts of this small Sudan virus outbreak, but the situation was very different in 2014, when there were thousands of monthly cases in several West African countries. Yeah.
I think the other piece that was implemented pretty quickly with the most recent in the Sudan outbreak was the screening of travelers by the CDC. And so, and the kind of funneling of travelers through a subset of airports, and for our public health colleagues to have been connected to those individuals and to be doing monitoring. And so I think that sort of approach, where there is awareness from the public health perspective as to how many individuals are coming through, and they're in their 21-day period, assessing for any high-risk exposures. Because as we talked about before, the vast majority of individuals coming back from Uganda do not have a risk for Ebola. And that's just the facts. But as they're coming in with a fever, getting that additional information up front in a way so that we can take Ebola off the table and proceed with that very important evaluation for malaria and other treatable infections is just so important. Dr. Lazarus, anything to add before we take a look at any other questions?
No.
Okay, so I'm just learning how to do this. So we did answer that question. So we have just a couple minutes left. Any pearls that you'd like to share with the audience, something you've learned recently or experienced in evaluating a patient returning with fever? I remember one in the past couple of months where this patient did not take their malaria prophylaxis, did end up getting hospitalized, did fine, but swore never again they would take their malaria prophylaxis every time that they went. So that really resonated with me, and the opportunity that we have to share that with our patients and give them the tools they need to prevent infection is a really important responsibility.
Yeah, I agree. I see patients both in the inpatient and the outpatient setting. So it's one of the questions I ask. It's fairly simple to ask. Do you anticipate any travel in the next few months or in the next year. You can catch a lot of possible travel that way.
Okay. I see one last question about the positive and negative predictive value of the binax malaria test. You mentioned that it had great test characteristics. Do you have that at your fingertips, Dr. Lazarus?
Yeah, I think that the specificity is in the very high 90s. The sensitivity, these are sensitivities and specificities that were tested in the US, so not an endemic region, so relevant to us. So the sensitivity is more in, I think, the mid to low 80s, which emphasizes the need when there's any sort of residual suspicion for malaria for a second test or for a rapid smear. You know, in fact, in our EMR, when a rapid test results, there's, you know, a disclaimer underneath emphasizing this. You know, if appropriate, you know, send a second rapid antigen test.
And actually, I was able to, as you were answering, you are correct. I was Googling and I found a paper reporting sensitivity in this study at one teaching hospital of 84.2% and 99.8% specific. So there may be better papers out there, but you highlighted the main points there. Okay. Well, thank you to this. Thank you, Dr. Lazarus. Great talk. Thanks to everyone for joining us. And we will obviously be putting on other webinars in 2023, but until we see you then, have a very happy new year. And thanks again for joining us.
Yep, we were so happy to have you.